Good afternoon and welcome to the CAQH webinar, Proven Strategies for Improving Director Accuracy. My name is Karen Waller. I am Director of Marketing and Communications and will be the moderator for today's webinar. Before we get started, I'd like to review some housekeeping details for everyone that's listening today. Today's session is being recorded. Next week, you will receive an email that contains a link to the on-demand webinar that you can share with others or review the webinar again. Both the recorded webinar and the slide presentation will also be posted early next week on our CAQH.org website. Your phones will be muted throughout the webinar today, so please submit all of your questions online. You can ask a question at any time throughout the session. You just simply type the question into the right-hand side of the GoToWebinar panel. We'll address your questions at the end of the presentation. Now I'd like to introduce today's presenters. They are first Ann Brisk, Director of Business Development at CAQH, and also Ron Wong, who is the DirectAssure Product Manager. Now I'll turn the presentation over to Ann. Ann?
Great, thank you, Karen. And thanks everyone for joining us today as we talk about this always current and important topic that's affecting everyone in the healthcare industry. So today we are going to touch on, I'm basically going to be covering some background on CAQH as well as our specific solution that we've developed for directory maintenance. And then Ron will be doing a deeper dive into what we've essentially learned and how we've evolved as since we've launched this product in January of 2016. So first I'd like to start off talking a little bit more about CAQH. Most of you are probably familiar with CAQH, but I do want to make a couple of relevant points about the organization. First of all, we are a nonprofit organization. We are essentially an alliance of health plans and the organizations that you see on this page that have come together in order to collaborate to solve issues just like the one we'll be talking about today. So essentially, you know, we don't work in a vacuum. We work hand in hand with health plan organizations in order to develop the types of solutions that will help reduce administrative costs in the healthcare industry, and that is our focus. We have a number of solutions that we offer in the industry, and many of those you're probably familiar with today. A lot of people in different health plan organizations and other types of organizations participate on CORE, and that is where we work on operating rules for the industry to help maximize the movement from manual-based transactions to electronic transactions. And in particular, we actually published the CAQH Index, which is available to everyone on our website, and it actually benchmarks the transition from manual to electronic transactions for both payers and providers. We do offer a number of other solutions that are focused on provider data, and specifically, many of you are probably familiar with ProView, which is our provider data solution to help collect a lot of the relevant credentialing data that's used not only for credentialing but other purposes too. We've recently launched Verified, which is a new CVO solution to actually verify all the primary sources that are required in order to decision and bring a provider onto a network. We'll be talking more about DirectAssure today. Sanctions Track helps with ongoing monitoring of providers that's required by NCQA. And Enroll Hub is an additional solution we've launched to help accelerate the movement from check-based payments to ACH-based payments. And finally, COB Smart is another solution we launched recently that's helping to identify overlapping coverage for health plans by their members so that they can more efficiently pay claims. So one thing we always just like to recap is the regulations that are affecting us all. And of course, that's really why we're here today. But it's important to understand that this need for regulations really came out of the fact that both federal and state governments realized that patients and members are having trouble finding and locating providers. Certainly through no fault of many of the health plans that have been trying to get these types of updates from providers, it's hard to keep track of who's practicing where, what information to publish, without kind of standard processes in place to maintain that information. So of course CMS launched a number of regulations specific to Medicare Advantage plans as well as Medicaid, and in addition for marketplace plans that are offered both through the federal marketplace as well as some of the state-run marketplaces. And then of course NCQA added in to help also find ways to help health plans address this issue. And then many states are starting to basically kind of add on to the requirements with state-specific mandates. Of course, California really stands out, I think, as an example of kind of the most rigorous requirements. And we've talked to many, many organizations that are really struggling with how to meet the specific requirements for outreach and then maintenance, within the state of California if they operate there. So obviously, I think the need is apparent, the regulations have been introduced, and now we're all working on how to not only, comply with the regulations, but again, most importantly, making sure we can put the most accurate data in front of health plan membership to help them find providers. So as we approach these types of issues, it's important to understand how we approach it. And again, we actually, come back to the table, and actually starting in basically mid-year 2015, when the new regulations came out from CMS, we sat down with the member health plans that we work directly with to collaborate on how to build a solution. And these are kind of the key issues that we really focused on in terms of trying to address what we thought would be kind of the most, the biggest obstacles to rolling out a solution. First and foremost, I think we all recognize, and certainly anyone on the provider side of the equation recognizes, that we have a lot of organizations that are doing outreach. So basically every health plan that operates within these certain lines of business is doing outreach on a quarterly basis to every provider that they do business with and that they list in a directory. These forms of outreach can be many different types. So it could be email, fax, there's a lot of phone calls being made, and even direct mail where there's kind of a call to action and a way to provide updates back to health plans. We don't, generally we don't think that's very sustainable for either side of the equation. So certainly when we have opportunities to consolidate that outreach and do it on behalf of many plans to a single provider, that can benefit the entire industry. On the health plan side of the equation, what they're dealing with is not only doing this outreach, but bringing this data back in, comparing it to what's already in their various databases, and then making decisions about what to update. This takes a lot of resources, and we've learned firsthand as we've worked with 30-plus different organizations that it is significant. And it doesn't matter if you're a large or small plan. This takes a lot of work. It takes real people looking at data and then making decisions about what to update. And finally, what this really kind of boils down to is, even if we go through this process, do we have good data? And one thing we've certainly noticed is that really depending on who you call in any given provider organization, you might get a different answer on these specific questions about directory data. And certainly when CMS calls to do auditing or monitoring of a health plan directory, it's really based on the person that's answering the phone. But that is, in fact, how they will make a decision regarding the outcome of that audit. So going to the next slide, as we really approach this particular problem, one of the things that obviously occurred to everyone at the table was that we have a really good base at CAQH for provider outreach and communication through CAQH ProView. It is essentially the default way for most of the healthcare industry to collect provider data, primarily for the purpose of credentialing, but also to maintain and update provider records. Currently we have over 1.4 million unique participating providers, so belly buttons if you will, of all different types that are participating in ProView. And more importantly, over 900 different types of organizations that are accessing that data when they need it. So we have a really good platform essentially to build from. We know that providers certainly recognize CAQH and are used to the reattestation process that we have them use today. Next slide. So what we did essentially is we developed on top of CAQH ProView our new solution called DirectAssure. And again, this was actually launched in January of 2016. But the whole intent was, again, to consolidate more of that outreach and those updates made by providers between health plans and providers. There's really three key components to the solution. First of all, there are outreach requirements as mandated by CMS to contact providers at least quarterly and ask them to update their directory data. So we do meet those requirements through the solution. Once we engage with a provider, we give them essentially what we call a snapshot, a provider directory snapshot of their existing data that's already in CAQH ProView. We call their attention to it. We have them focus on it for the purpose of communicating any changes back to the health plans that need it. And then finally, and very importantly, we produce the output files that plans have to consume in order to compare and then determine what type of information they want to update in their system. So there's a number of different options we offer around those outputs, and we work closely with plans to really work within their operations and processes to be able to consume this data. In terms of outreach, there's a number of different ways, and in many ways providers are a lot like consumers. However, one thing that we really base most of our outreach on for DirectAssure is through email. And fortunately, we have created a really strong communication path with our normal ProView outreach that we do via email to providers. They're very used to receiving them. They're used to the reattestation process. And what we're doing here is now we're communicating to them about these provider directory requirements, explaining which health plans have identified them for directory maintenance, and then giving them the ability to log directly into the system and make those updates. Even if they come into ProView just to do normal attestation, we also will call out to them that there is a need for them to look at their directory data, so we're going to also communicate once they log into the system. And then finally, if we don't get a response from a provider during that normal quarterly outreach, we do have a backstop in terms of actually calling those providers at least every 6 months to determine if they're receiving our emails and if they're able to make the updates to their provider to their directory data. So again, this is a key component of what we offer, and we do make sure that it meets those CMS requirements. So I'd like to just take a closer look at what the actual snapshot looks like. And again, all of the data you're seeing in the screens that we're going to run through are already in CAQH ProView. So we're taking the data out of CAQH ProView, and we're simply calling the provider's attention to this information so that they can make those updates directly. As you can see along the top, we list all of the health plans that have identified that provider for quarterly outreach. And then the first part of the scroll-through page that we give them is for their personal information. So gender, type 1 MPI, what languages the actual practitioner can speak, and then whether or not they are individually participating in Medicare and Medicaid. We do list their current education, which fortunately doesn't change too much. We could get updates to that, of course, along the way. And then finally, any specialties that they list within their ProView application. Specialties are important because that's obviously calling attention to where they're listed in a directory. The next and probably most critical part of our engagement with the provider is around their various practice locations. So whether they have 1 or 5 practice locations listed in CAQH ProView, we will list each of those out in a scroll down. And then they can review the specific information regarding the name of the practice, of course, the actual practice address, so where they are seeing patients, the group name, phone number for making appointments, any fax number, type 2 NPI. We do list office hours. We don't find that CMS is paying particular attention to office hours at this stage, but we certainly want to propose those and make sure that they have an opportunity to publish those. Any languages that the actual practice itself can support. And then, and these are very important, whether or not each practice is currently accepting new patients, any patients through a physician referral, and and of course, whether or not they're accepting any new Medicare and Medicaid patients. And these can change. And our organization might be accepting new Medicaid patients in one quarter, and then in a couple of other quarters, they might make a decision to stop accepting new Medicaid patients. And then finally, we do have some requirements around how accessible is the practice. So again, all of this information is listed out. What we are finding when we actually see the response and changes made is that a lot of providers are cleaning up practice locations and really getting that information to be very current regarding not only what's in DirectAssure, but also in CAQH ProView. So finally, after they go through, as you can see, a fairly simple process in terms of fields to review, they now have the opportunity to indicate that they have reviewed their provider directory snapshot through checking this box and then attesting. So this is really a nice feature in that it's sort of once and done for a practice manager or provider that's doing this. And they're doing both at the same time. So if they are reattesting, that is starting the new 120-day clock as far as when they would need to come back in to reattest. And they're completing both of these transactions in one step. We really want to kind of get to the meat of how well this has worked, frankly. And as we've done significant outreach on behalf of over 35 different health plan organizations, together we've had over 800,000 rostered providers in the system. And we've made to date over 3.5 million emails that we've sent out to providers. What's great and what we found out is that about 90% of the time they are responding to that initial email that we send to providers. And to follow up, we've also made, since the launch of this about 18 months ago, over 500,000 phone calls. So we're also continuing to do outreach to providers through these phone calls. We've actually now seen over a course of a 90-day period that we are seeing about a 72% response rate for all providers that are coming in to review that data. So I think, as many of you know, trying to get providers to respond to the various outreach methods, 72% is a very good number, and it does show that providers are certainly engaged in using not only CAQH ProView, but specifically using DirectAssure. So as I mentioned, we're happy about those results, and we are getting very positive feedback from providers as they use the solution, and they see the benefit of doing this all in one place. So on that, I'm going to go ahead and turn it over to Ron Irwang, and he's going to be drilling deeper down in how we've really evolved the solution and will continue to evolve the solution since we launched 18 months ago.
Thanks, Ann Brisk. So I wanted to go into some of the results that we've seen and also the findings of CMS and really explore the different dimensions of accuracy as it relates to provider directory. So as many of you know, the provider directory accuracy problem has been a long-standing issue. It's been that way for years. It's only in the past couple of years that we know just how serious this issue is. So to rewind the clock back to 2014, Journal of the American Medical Association conducted one of the first studies showing that health plan directories are on average around 51% inaccurate. So that came as a big shock to many in the industry that the data was that inaccurate, and some felt like, well, that was just one study. However, subsequent studies from health fairs and findings from New York State government and California as well have shown similar results. And most recently, starting in 2016, CMS started conducting monitoring activities around Medicare Advantage health plans. Many of you on the conference call have probably received results from them. On the right-hand side here, you see the data elements that are monitored or audited. So CMS has contracted with another organization to make phone calls to random samples of locations within health plans provider directories and inquire about the accuracy of these data elements. And in the fall of 2016, so not too long ago, CMS had the opportunity to report some aggregate results, and that's what you see on the left here. So the 41%, that's the average rate of inaccuracy for an average health plan. And then the vast majority of health plans have inaccuracies between 30 and 50%. So it's a pretty narrow range of very significant inaccuracies. Like I said, many of you have probably seen similar results in your monitoring reports from CMS that you've had to respond to. Let's move to the next slide, please. So let's drill down a little bit deeper into what those inaccuracies are. I'll orient you around the graphs that you see here. So on the left-hand side here, you see the overall error rate that CMS has reported. So, we'll call it 50% inaccurate, 50% inaccurate. And then if you take a look at the portion of location records that are inaccurate, what you'll notice here on the right-hand side, when you drill down into how those deficiencies are broken out, the vast majority of them are provider not practicing at location. So what that means is if a patient is trying to make an appointment with a provider, they're unable to do so because the provider's not practicing there. That's really the litmus test that CMS is using to determine whether a record is an error or whether it's accurate. So there are multiple motivations for why providers are over-reporting locations. I'm not going to go into every single one of them in detail. If you'd like to talk about it, happy to do so. Reach out to me on LinkedIn. But I'll go into one of the root causes that we found in interviews and surveys and focus groups with the provider community. A lot of provider groups are quote-unquote defense related to claims. There's an assumption on the provider side that if a health plan doesn't have a location within their claim system for that provider, and the provider happens to submit a claim from there, they're covering for a colleague, and maybe their colleague's on vacation, they need to see a patient there, that claim may be denied. So that anxiety or the fear on the provider side causes many groups to report every single location for every provider within the group to health plans. And that's a big driver of that inaccuracy there, and why that makes up such a high percentage of the overall inaccuracies within provider directories. So we found this to be a top reason and contributing to the topmost efficiency. And really, it's a strategic opportunity for health plans to solve for this problem. So this next visual here is kind of a restructuring of the data that CMS reported. But the average health plan, as mentioned before, around 50% inaccurate. The below average plans are getting warning letters from CMS. The bottom axis here is the accuracy of health plans directories, just to remind. But in general, as health plans become more accurate, so arrive towards the right of the chart here, they're reducing their audit and compliance risk. It's likely that the regulators are going to, when they do institute and actually enforce the fines, they're probably going to get to the most egregious offenders first, right? That's some simple intuition there. So for the average health plan, if they want to make some great strides towards accuracy, if you take a look at this here, the biggest opportunity for them is to solve for this practice location issue. So how do they identify those locations within the directories that are in error? How do they do that in a scalable, reliable, and automatable way so that they can maximize their accuracy gains and reduce their compliance risk? Okay. So I want to walk you through a few scenarios. So as CAQH has worked with a number of health plans, we identified some scenarios where there are really reliable positive signals for health plans to suppress locations that are already in the directory. So let me orient you here around this table. This table represents a list of providers that a health plan has within their network, a list of addresses that they have for those providers on their directory, and then upon comparing that data with data that CAQH has, that providers have attested to and self-reported, what was the outcome of that comparison? Was it a match or was it not a match? Okay, so starting from the top here, Dr. Seth Hollander practices at 123 Main Street. CAQH says that Dr. Seth Hollander also practices at 23 Main Street, and once a week. So health plans are likely going to view that as a really positive signal to keep that location within directory. So that's a good positive signal. The second row here, you've got Dr. Seth Hollander. He's also listed at 987 Maple Avenue by the health plan. And CAQH says that, well, Dr. Hollander hasn't reported 987 Maple Avenue in the portal. So it's likely that that location should be suppressed within the health plan's directory. And moving down the chart, Dr. Julie Nangia practices at 231 Broad Street, or is listed as that in the health plan's directory. CAQH has that location, actually. But Dr. Nangia within CAQH's portal says that she stopped practicing at that location as of March 2017. So if the health plan sees that, they're going to use that information, and so really strong negative signal that that location should be suppressed within the health plan's directory. And then Dr. Victor Sung, the very bottom here. So if you took the last row, the health plan has Dr. Sung practicing at 882 Gessner Avenue. CAQH has that location as well. However, Dr. Sung has told CAQH that he's only covering or filling in for colleagues here. So many health plans are going to take a look at that and say, that location should be suppressed because it's likely that a patient's not going to be able to make an appointment with Dr. Sung at 882 Gessner Avenue. Okay, let's move to the next slide, please. So CAQH made a decision in January of this year to get more granular in the questions that we're asking. We were previously just asking a very simple question of, are you practicing at this location, yes or no? Now we're getting a little bit more granular to better help inform the suppressed published decision by the health plan. So as you can see here, we're asking questions about how frequently the provider's practicing at a location, if they're simply filling in or covering for colleagues on an as-needed basis, or reading tests. And so we've been able to require this question of a large percentage of providers within the system, and we've been capturing some good information here. And the responses here are a good counterweight to the motivation by many groups who were previously playing defense by over-reporting locations. They can still report these locations. They just need to be a lot more specific about the actual nature of practicing at those locations. Okay. Let's move to the next slide here. So this is data that we collected about a month into after we had released this functionality within the portal. So as you can see here, the vast majority of providers and their locations are reported as the provider practicing there at least once, 1 day a week. So your health plans are likely to use that as a very positive signal that these locations should be published within directory. However, if you take a look at the top here, the suppressed bracket, so I've never practiced at a location, I don't practice here, I no longer practice a location, or I read tests or cover or fill in for colleagues. So while each one of those is a smaller bucket of responses, collectively they're about 34% of the response volume. So that's a significant number of locations we're capturing good information for that health plans can be confident in using to suppress the locations within their directories. Okay. Let's move to the next slide here. So what I wanted to go through is an example, a brief case study of how United Healthcare has collaborated with CAQH in utilizing a lot of the data and outcomes that we just previously discussed to get some good outcomes. So just as some background, United Healthcare was an early adopter of the CAQH DirectAssure platform. They've been using the system for nearly 2 years now. And around the same time, CMS came out with the results in fall 2016 that the provider non-allocation was the most important issue. They saw that as a strategic opportunity for improving their directory accuracy. So they wanted to find an economical, repeatable, and scalable way to identify those locations that should be suppressed. Okay. Let's move to the next slide to get in a little bit more detail. So this is the same visual that you saw before, but United Healthcare had set a target of getting to over 85% accuracy in total. They felt like that was a safer zone to be in to be able to minimize and reduce audit risk. And they felt that, they saw the same thing that we did, that reducing practice location errors or where providers not actually practicing a location held the most promise for maximizing accuracy gains. Of course, they also want to work on the other ones, so phone numbers, incorrect addresses, and suite numbers, which they've been making progress on, and they've been utilizing a lot of the data from CAQH as well. But they've spent a strategic amount of time on the practice location issue. Okay, let's go forward and understand how they did that. So this is a zoom in or kind of a recap of the scenario that we described before, where United Healthcare had 3 locations for a provider, but in the CAQH system, we had only 2 of them. So 231 Broad Street, United Healthcare had, but CAQH didn't have. So United Healthcare decided that that was a good signal to suppress that location within their directory or remove it. Now they're not deleting it completely; they're just making it invisible within the directory. It's still within their claims system, so if claims are being submitted, those will be paid. So that alleviates a lot of the concern on the provider side. And if the provider changes their location and comes back there, they can always bring it back as United Healthcare has good signals for that. But they decided to make a scalable decision to automatically suppress these locations. Okay, let's move to the next one. So they didn't do this. They did this with eyes wide open, however. So they took a really practical approach about being skeptical of the data first before fully investing in scaling this outcome. So, when they first had this hypothesis that these locations should be suppressed, they actually went ahead and called up 60,000 locations, practice locations where providers were listed, to validate that these locations shouldn't be published. And what they saw over the course of a couple months is that 80% of those locations should not be published. They used a very similar methodology that CMS was using, kind of a litmus test of would a patient be able to make an appointment with a provider at that location. So they saw these results, they were very encouraged by it, and decided to scale up the use of the system to over 200,000 providers to suppress these locations. So they're automatically suppressing these locations as invalid within their directory. And as I mentioned before, they are allowing for the reversing of those decisions if they have other information that shows that the provider is actually practicing there. But in the vast majority of times, 80% of the times, those locations need to be suppressed. Not only that, but as we found this result or this outcome from United Healthcare, we started talking to other health plans about it, and they wanted to try it out too. And we encouraged them, just as United Healthcare had, to independently validate those results to see what they got. And 3 additional health plans found that this scenario could be used 77 to 80% of the time. So they viewed it as highly reliable as well. Okay, let's move to the next slide. The second scenario, so this is more around those detailed questions or the detailed responses about how a provider is practicing at a location. So if you take a look at the left-hand square here, CAQH performed its own analysis about the reliability of these scenarios, where we found that if a provider says that they're not currently practicing there, it's 83% likely that that location shouldn't be published in the directory. Or if they say they're reading tests or covering or filling in for colleagues, it's 87% likely. Now, United Healthcare performed its own analysis across a population of 100,000 providers. They found some similar results. So they actually found that the currently practicing equals no was more reliable than what we found. They also saw that reading tests and covering or filling in for colleagues were around 60% reliable. It's not still highly valuable and useful, but not ready yet for them to automate across that scenario. Now, United Healthcare has also said that there was some lag between the validation work and when we captured the responses from the providers. So they're going to be redoing the validation work to see if they can match what CAQH saw. And if the scenarios are greater than 80% reliable, then they're going to automate on them. So for sure, they're automating on the currently practicing equals no, and they're going to be seeking other opportunities to suppress these location instances. So some practical takeaways from the United Healthcare case study. It's important to solve the biggest problem first. And a lot of health plans, when the regs first came online, wanted to solve for every single data element and every single rule and requirement from federal and state regulations. And I heard from one health plan, they said that was almost like boiling the ocean. If you focus on the most prevalent error, highest priority one, you can maximize your gains and get to the safe zone a lot faster. So it's also important to find those scalable scenarios that you can easily identify, that you can automate with just a little bit of technology, and then get those things to be suppressed. Of course, you need to invest a little bit in technology, but before that, you need to convince yourself that these scenarios are reliable. So measure the baseline accuracy of your directories, measure the reliability of these scenarios. We encourage you to do that, and happy to share methodologies in which you can do that. Because you need to trust it before you invest any amount of IT resources into utilizing this data. We encourage you to do that for us or any vendor that you decide to choose. And then once this low-hanging fruit of accuracy gains have been secured or exhausted, you go to the next one. Go to phone numbers, go to suite numbers, go to the other data elements. Okay. So we'll move to the next one. So speaking of going to the next one, the phone number inaccuracy is, as CMS found, the second most prevalent, so 10%, also very highly weighted. We'll go to the next slide just to show how we're trying to tackle it right now. So we're inserting strategic pauses within the provider workflow within the CAQH portal, where even if a provider's already entered a phone number, we're asking them on a periodic basis to reconfirm that this phone number is useful for patients to make appointments with a provider. So we want to keep asking this because, as you may know, provider data ages on a pretty regular basis, so you need to get the freshest information from the provider. Let's go to the next slide just to see some of the early results. So we released this pretty recently in April, but since April, we've seen a tripling of the change rate in the phone numbers. So where around 1% of providers were updating their phone numbers, we're now seeing over 3% of providers updating their phone numbers. We're seeing some early signs of accuracy gains here as well, but we're going to give it a little bit more time to have a more significant sample size before we report the final outcomes here. But the major takeaway here is accuracy isn't a once and done thing. It requires constant successive efforts to address the most important deficiencies. You have to do it in a fresh way that engages the provider and gets the most accurate responses. On our side, we are constantly measuring, constantly iterating, constantly innovating to be able to maximize the accuracy gains. So the final thing that I wanted to show you is some sneak preview of upcoming functionality that we'll be releasing within Q4 of 2017. So in this future iteration of DirectAssure, we're going to take the data that health plans already have within their directories, automatically compare that with data that we've already got within the CAQH portal, and present the discrepancies and the deltas to the providers and have them explicitly respond to it. So what that does is it takes the burden of comparison off of the health plan's plate, automates that within the system, and it brings the provider directly into the reconciliation job. We can tell the provider, health plan says they've got this, you say they have this, what's the deal here, are you actually practicing here or not, how often are you practicing here, and then and some other questions about the plan participation. So, we've gotten some early results. So, as providers have been presented these types of questions, the accuracy rate that we're getting is around 86 to 87% accurate on resolving these health plan discrepancies. So, highly accurate, highly reliable responses. And we'll go to the next slide just to show you the other questions we're asking. So, we're also getting more specific. Instead of asking a generic, are you accepting new patients, are you participating in plans, we are doing that on a plan-specific level. So are you participating with Aetna at this location? Are you accepting new patients with Aetna at this location? And then providing that context to the plan so that health plans can be even more confident in the results that they're getting from DirectAssure to use to update their directory information. Okay. So just in summary, DirectAssure is a proven solution that health plans have had measurable success with in increasing the directory accuracy, reduces the amount of time health plans and providers have to spend in solving for this problem, brings health plans into greater compliance as we're automating outreach and logging it for compliance purposes, and also just in general, increasing overall accuracy, reducing costs both on the provider and the health plan side, and very importantly, streamlining the administrative effort, reducing the friction around this process. And then, of course, and you know this, but CAQH has a very strong engagement with over 1.4 million healthcare providers. They trust CAQH. They want to provide the best information to CAQH for multiple purposes. So we're leveraging that engagement, that relationship with those providers. So I'm going to pass it back to Karen Waller as we're going into the Q&A section of the webinar.
Thank you, Ron. Now is the time, again, as a reminder during the webinar, when we're going to answer questions from individuals who are listening in. Again, please submit your questions by entering them in the questions section of the panel on the right-hand side of your screen, and we've already gotten some questions in. First question, and this is for Ron. Have you surveyed providers for feedback on DirectAssure and what they think about the solution?
That's a great question, Karen. So we have performed some surveys to the provider community on how they react to the DirectAssure solution. So just some high-level results. That 73% of responding providers said that the user experience was easy to understand, which we highly value. We wanted to make the process as easy as possible for providers. 58% said that they were doing this for the right reason. They wanted to keep their information up to date for patients. What's interesting is 53% of providers said that they were updating information, responding to requests from CAQH for directories because, quote unquote, CAQH requested me to do it, so I felt obligated to do it, which I think speaks to the engagement that we've got with the provider community and their responsiveness to our requests.
Okay. Actually, there was a follow-up question to that. What is the encouragement for providers to respond to CAQH versus health plan outreach? Why do you believe you're getting a better response than individual health plans?
So if I'm putting myself into the provider's shoes, and they're inundated with phone calls all the time, not just from health plans, but from other organizations for administrative purposes. So they're just trying to make their own lives easier. So being able to respond to information or requests through a single source or a single platform just makes their lives easier. So they're embracing this promise of being able to minimize the outreach health plans are performing to them.
Thank you.
And Karen, I'd just like to add, this is Ann, that I think it is always important, and we always try to reinforce that ultimately having this information be accurate in directories will help drive patients to see them. So we certainly, while there's no requirement that they respond, we certainly think it's in their best interest, and we always want to reinforce that when we're communicating to them.
Thank you, Ann. And actually, this is a question for you. Does the size of the health plan matter? In other words, can a small or regional plan anticipate the same kind of results as United?
Yes, I would actually say that's a definitive yes, and here's why. As you recall, when we showed you how we conduct the outreach and the communication, basically all the plans are listed together when we're conducting outreach at that point in the quarter for everyone. So they'll see big plans, small plans, all the relevant plans, and I really think that's what drives it home for these provider organizations, because they realize, hey, I've got 5 or 6, plans of all different sizes that I'm actually covering by making these updates right now. It makes it so much easier for them, and they really see the value in going through that process. So certainly our process is really meant to leverage plans of all sizes.
Thank you, Ann. This is a question for Ron. The system seems very provider specific. Can one practice link individual provider accounts together and manage under the practice, or must each provider update his or her information?
That's a really good question, Karen. So, the platform is provider-centric. A lot of the questions that we're asking are individual practitioner-centric, and right now we are seeking to get the most accurate information for those individual practitioners. I think a large part of why we're in the situation we're in right now with directory inaccuracy is we've been getting aggregate reports from groups that haven't been very accurate. So we want to insert the strategic pauses so that they're answering questions at a provider-specific level. Now, that being said, we do have functionality for groups to load information that is common across all providers. We've got our practice manager module. So for information that should be common across all providers, we have ways for groups to be able to load that information within our system.
Okay, thank you, Ron. Another question for Ron, and Ann can weigh in. This person wants a little more detail about how it actually works. Is there a manual comparison between the health plan roster and the CAQH roster, or how does that?
Yeah, so with the 1.0 solution right now, or the current version of the DirectAssure solution, there is comparison required on the health plan side. So what we report out right now is what the provider last updated and last attested to, and then it's incumbent upon the health plan to take a look at that and see how that compares with their current directory information. And as you saw in some of the scenarios, there's some really valuable scenarios where information can be updated. That being said, this next generation of the solution, which we're targeting for Q4, is going to take that burden off of the health plan and automate that within the system. So all a health plan has to do is send us all the locations and the provider lists that they've got, and we'll bump that up automatically and then report out the deltas and also include the provider in that reconciliation process. So it's kind of a current state and a future state there.
And as an add-on to that, is CAQH planning to add product-level validation in addition to the current plan-level validation?
So we know that product or network-level validation is important for regs such as California Senate Bill 137. That's the one that has been most explicit about confirming that level of information. We are currently asking questions at the plan level. As you said, we're asking, does a provider practice and accepting patients for, a Cigna or an at a location? We do want to make movement towards adding that product level or network level confirmation. I think there's a lot of interesting problems that need to be solved there in terms of getting to the right person in the provider group and making sure that their responses are reliable and accurate. But that is absolutely within our future roadmap.
Okay. This question is for Ann. Does this solution only work for those providers who are currently within CAQH ProView?
Yes, essentially as I mentioned, all of the data that we create that provider snapshot with is based on data that's in CAQH ProView. We can do outreach in order to incent the provider to come into CAQH ProView, but we do have to have their data in there in order to be able to provide that directory snapshot for them to update.
Okay. And is it how does CAQH go about adding new providers to ProView when a plan has them on their roster and would like to include them in the directory solution?
I can take that one. So we've got an invitation process where we have contact information on the provider given to us by a health plan or multiple health plans, and we will invite them into the system, and we'll do that through multiple channels. So we'll perform USPS invitations where we give them the information to log in. If we've got good email addresses, then we will invite them to participate via an email link as well. And we'll give them quick and easy steps to get started within the CAQH portal.
And here, one part of our sort of overall process when we're talking to plans is to be able to do a match specifically against the directory set of providers, which can actually look different than the credentialed set of providers, because who you might list in a directory could be different. So that's actually part of our process as we talk to plans. We can do some analysis to help you understand, what percentage of those providers are already in CAQH ProView.
Okay. Thank you, Ann. And again, I invite people to submit the questions into the right-hand side of their screen into the questions section. We have some other questions coming in. Let's see. So when CAQH does outreach to the providers, how do they avoid conflict between CAQH outreach to that provider and plan outreach to that provider?
So frankly, it's a work in progress because health plans, it requires action on the health plan side as well. Health plans need to start dialing down the outreach that they're performing, and as they are increasing the usage of the CAQH solution for directory updates. So, of the plans that are currently using our system, we do have plans and strategies in place to, as we gain greater and greater coverage of their providers and provide increasingly accurate information to them, they're depending more and more on the solution and then starting to dial down the outreach, or at least align the outreach that we are performing so that we're speaking in the same language, directing the provider to the same place to update their information.
Thank you. So we've, again, received several questions about slides being available online and this recorded webinar. I'll repeat again that if you are participating in this webinar, you will be sent a link early next week that will have a link to both the slides and the recorded webinar. And also early next week, slides will be available on our website at www.directassure.org. So we'll make all of that information available to you. How does, a question about payment, how does this work? Do health plans pay? Do providers pay? What is the charge? What's the cost of this? Anne, I'll have you answer that question.
Yes, so first of all, it's important, just as a backdrop, for both CAQH, Proview, and DirectAssure, providers don't pay. We don't charge providers anything. We want them to engage and respond. So we know the best way to do that is not to actually charge them anything, but to make the solution available to them. And then as far as who's actually kind of footing the bill for this, if you will, in terms of the cost, it is the health plan organizations that use the solution. There's really a primary component to the solution is an outreach fee, and we do charge that essentially on a quarterly basis, and it adds up to essentially an annual fee that an organization would pay per provider for us to do the outreach, and then also for us to send the data back to the plans and help them incorporate that data. So we'd be happy to share more specifics about that specific fee directly with you if you do have some interest. And then, as I mentioned, there is a requirement for providers to be in Proview, and so the inherent costs and standard pricing for Proview does apply. And again, we can help an organization do the analysis to look at all of their directory providers and then compare that to understand how many are already in Proview today and then what the additional outreach fees would be.
Okay, thank you, Anne. So there's a question about how often is the provider contacted to review their information and verify their information?
So we've aligned with the CMS Medicare Advantage requirement of quarterly outreach. Some of you may remember that it was supposed to be monthly at the beginning, but then the CMS decided to dial it back to quarterly. So we've aligned with that. So we're sending emails on a quarterly basis to each provider to ask them to update their information and attest to its utility for use in directories. And then we're performing phone calls for those who don't respond in a timely fashion.
Thank you. There's been several questions. I think these refer more to Proview than necessarily to DirectAssure, about allied health professionals, specifically one about employee assistance professionals, and the application and whether the application is different for different kinds of healthcare providers. Can you take that, Ron?
Yeah. So right now it's a standard application for all provider types. There's some, in the actual profile, there are some questions that are a little bit more provider type specific. So, for instance, the specialties list and some of the boards, those are on a provider type specific basis. But it's a fairly standard application across all provider types. We're looking to see opportunities for some of the non-medical practitioners, how we can customize the application a little bit more. But in the current state, it's a fairly standard application.
Okay. And this question is for either Anne or Ron. When the provider information is being compared between the health plan, and CAQH. Does it include tax IDs associated with those addresses, or is it addresses only?
We do include tax IDs. It's a required field for any location or group that is reported within the provider's profile, and that's made available to the health plans for matching and reconciliation purposes. So it is absolutely required.
Okay, thank you. Is there a contact for the health plan for providers who are found to have changed practices or addresses or no longer practice after the initial outreach? So is there a direct contact between the provider and the health plan, or are we the intermediary there?
Yeah, we're really the conduit or the intermediary, as you say. Now, I know that a lot of times health plans will contact the provider directly and say, I found something to be a little bit out of date. Could you please, update it within the portal? So, that's fine too. I think as we're directing any provider to make appropriate updates in the same place, that benefits everybody.
Okay. Thank you very much, everyone. That concludes our time for our webinar today. I do realize that there are a few questions that weren't answered, and we will do our very best to reach out to you individually to answer those questions. Again, just to repeat, both the webinar, recorded webinar, and the slide presentation deck will be available early next week. You will be receiving an email that directs you to that location. Again, we thank you very much for participating today. If you have any questions, you can visit the website for more information. That website is www.directassure.org, or you may outreach directly to Anne or Ron at abrisk@caqh.org or r.erwong@caqh.org. Again, we thank you very much for your participation and enjoy the rest of your day.